Welcome to the Modern Intimacy Podcast, a show about mental health, sex, relationships, education and tips, and those private things we need to talk about more publicly without restrictions. I'm your host, Dr. Kate Balestrieri. A licensed psychologist, certified sex therapist, packed couples therapist, and sex addiction therapist, I know that mental health is directly tied to the quality of our relationships and our sex lives. I'm passionate in my desire to smash stigmas and shine a light on societal issues that may be negatively affecting our lives, relationships, and sexuality. During this podcast, I will also give you practical answers and insights to questions you've been wondering about. We should all have fulfilled, happy lives, and we get there by erasing shame, consciously digging deeper, building healthy connections, and by getting curious together. Thanks for joining me. Let's get started. Hi, everyone. Welcome back to the Modern Intimacy Podcast. Today, I'm really excited to have with me Dr. Sulman Aziz Mirza. He is a psychiatrist who is triple board certified in psychiatry, child and adolescent psychiatry, and addiction medicine, and one of my favorite content creators on TikTok as the Kicks Shrink. So thank you so much, Sulman, for joining me today. I've been really excited to talk with you a little bit about so many things, media and the mental health, and also I understand you're doing something like a ketamine treatment. So maybe we can talk a little bit about that in a bit.
Yep, definitely. Thanks, Kate, for having me on the show. So super excited to be here with you.
Yeah, thank you again. Can you tell my listeners a little bit about your background, how you got into this work, and what you're really passionate about?
I'm a psychiatrist. I'm based out of Northern Virginia. I am triple boarded, so adult psychiatry, child adolescent psychiatry, and addiction medicine. My main job is working with a local hospital system over here, mostly with children and adolescents. I do work in a partial hospitalization program. So it's kind of an in-between between outpatient and inpatient work, which has been, I think, really helpful. And it's really great. And also I do outpatient work with children and adolescents primarily. And then my private practice is based purely with adults with a major focus like on ADHD, autism, addictions. And then we do like the ketamine treatments, the Spravato, the intranasal S-ketamine for treatment-resistant depression.
Really interesting. So when you are working with folks who are experiencing depression and they're looking for alternative solutions, what makes them a good candidate for ketamine?
Yeah, so with ketamine, the FDA approval for it is for treatment-resistant depression. And treatment-resistant depression, it kind of is this, it's a wonky term because when people hear treatment-resistant depression, it means like, oh, nothing works for you, or you're somebody who cannot get better. And that's an incorrect kind of assumption from what the word is. Treatment resistant means is that the things that have been tried for you, whether it's medication or therapy or other treatments, have not been effective or have not produced essentially remission in the symptoms. So basically your scores, quote unquote, because we know that depression is more than just numbers on a paper, that hasn't gone down. It really kind of varies, insurance to person, to all these kind of differences between what is treatment resistant. So for certain insurances, we have to play this game. It can be 2 failed medication trials, and that can make somebody, quote unquote, treatment resistant. So typically when I'm getting patients, they've failed or not failed, but they've had multiple medication trials. They've been on like dozens of medications, dozens of combinations of medications, and things just haven't been as effective. They haven't been doing as well as they could be doing. And that's when they become a treatment or a potential candidate for something like Spravato.
Does someone have to wait until they've been in that high acuity state for so long before they can try this treatment?
Typically, because again, like when we play the insurance game and we're going through the FDA approvals and everything like that, they want to see that there have been trials of different medications. So, one of the things that my content is about is kind of my frustrations with the healthcare system and insurances and dealing with it and all the roadblocks that come up with it. So I have to have documented proof of like, these multiple failed trials. And I need to show the doses that they were on, how long they were on it, what was the effects that occurred, or what was the effects that didn't occur, so that we can qualify this as a, again, quote unquote, failed trial. So that's the issue that kind of like pops up a lot, is like, how do we prove what this is, to get insurance approval. Now we have a lot of these kind of ketamine clinics that are popping up, which are not FDA approved. What I always kind of say is these are other docs who are, making IV bags of ketamine and using that for depression treatments. So those ones, again, since they're out of insurance, they're usually cash pay clinics. That works a little bit differently. You don't necessarily need to kind of go down that whole route. So it just depends on how you want to approach it.
I think that's a really important factor to consider. Of course, people's resources can impact their access to care so profoundly and in a way that's so frustrating, because thinking about where we started this conversation, this language of treatment-resistant depression, it carries such a negative connotation, and the folks who need care the most are often left with the residue of feeling shamed because of the language that we use and the barriers to care.
Yeah, absolutely. It's one of the major issues. One of the things that when I talk with my patients, it's that, we see this kind of discourse that's out there on social media. They're like, oh, we're trying to destroy the DSM and we want to get rid of labels and all that stuff. I was like, the DSM is, when we talk about what it was meant to be, it was meant to be a tool, a research guideline booklet so that clinicians can communicate with each other, so that when you and I, for example, talk about a patient or a client and we say, I have a patient with generalized anxiety disorder, boom, I have an idea, a framework in my mind of like, what's kind of the situation that's going on. The DSM is not meant to be read. It's not like a book that we pick up on the weekend for like late reading and we're like, oh, let's check it out and see what's going on. And this is the psychiatrist Bible and we're just classifying people into checkboxes. No, that's not what it's meant to be at all. That's not what the interpretation has been. And that's kind of when we've opened up the world and when you can buy the DSM on Amazon and we can download the app, that's what happens then, is because everybody gets access to it and they're misinterpreting how it's supposed to be. And so these terms that are there, these words are there, the language that's there in mental health, it's so, it's a constant struggle of mine. When we say things like, oh, the weather is being bipolar, or my OCD is acting up, and these words have meaning, right?
They
They're
do.
not just, they're not meant to be kind of tossed around. And that's just how, again, it just comes into the lexicon and our language every day to day. So
I really appreciate you bringing that up. I think the DSM sort of took on a life of its own because it was meant to be a shorthand, right? A utility for providers to understand clinically what people might be experiencing. Of course, there's great diversity even within people who identify with certain clusters of symptoms. One person might have 3 of the 10 symptoms required. Other people might have a different 3 or 7 or something of that sort. So I think we really do run into this permeation and conflation of this tool into how we make meaning in our lives and how we construct identity, and then how we talk about ourselves and other people. And sometimes I think that gets really dicey, especially in the media when we're talking about mental health. And you made a really astute post the other day on TikTok talking about why it's so important for journalists not to talk about methods of suicide. And since we're talking about depression, I wonder, let's talk a little bit about that. What kind of expectations should we have for journalists who are trying to educate the public on mental health?
Yeah, and there's very well established kind of guidelines for reporting on suicide. There's a lot of the language. One of the things, first kind of thing that we try to do is say we're trying to get rid of the word commit suicide, right? We're trying that phrase of committing suicide to change it into died by suicide, just because we're trying to alleviate that aspect of morality, that sin that's there, that crime aspect. I'm a Muslim. I say this, and like there is this aspect where in Islam they say that Islam, or that suicide is the sin, right? And this is a thing that's there in other religions as well, not just Islam, is that it's a sin to commit suicide. So once we remove that kind of language of commit suicide, we take that aspect out of it, and we kind of, again, when we're reporting it, we're not supposed to be reporting with bias or other things that are out there. So when we say they died by suicide, you've taken that sin aspect out of it, that morality out of it. That's one thing. The other thing that we know is that when we talk about means and stuff, we don't talk about those things, right? This is, one of the reasons that the show 13 Reasons Why was so kind of controversial a few years ago was because, the main character's suicide was graphically kind of displayed. And what we saw, the research that was out there, you saw the Google trends, all the searches, the inpatient kind of admissions and emergency room visits, they all spiked after the premiere. And there was very much like, oh, we're seeing copycats because there is such a thing as a suicide contagion. So when people are exposed to suicide, hearing about somebody else's suicide, learning about means, it's really difficult because it puts the idea into somebody's mind who may not have had that idea before. There was a thread that I saw like on Twitter, and again, we can kind of talk about it, but like something about pulling something from Amazon. There was somebody was buying something, again, I don't want to give too much details, but there was a common ingredient that you could find on Amazon in food prep. And they were selling it at like bulk quantities, again, for people who are, again, using it for food prep, right? And it's a very common innocuous kind of thing. But when taken in larger amounts, it's a fatal substance. Because it's not meant to be done like that, just like kind of Tylenol, and we know those things. So what was showing up, the algorithm that was kind of showing up from Amazon was also people were buying this, and then the suggested items that show up on Amazon were like part of like a suicide kit, essentially. So like, how do you do this, and what are other things you need for this? Those are things that are automatically just from the algorithm popping up and showing up there. So people were like, we need to pull this. Amazon is promoting suicide and all these things. And the thread itself kind of, again, it showed this whole thing. So again, we've put this idea out there, like, so somebody who may not be thinking about it, now it's out there. So again, we're putting those thoughts there that may not have been there.
Right. Right. And I think for a lot of folks who experience the level of hopelessness and desperation that comes with being in that state of mind, when they hear things about what means might exist, it actually can provide them with a sense of hope, which allows just enough activation for movement sometimes. And we don't want to create a situation where that's the activation, right? We want activation toward resolution, toward help, toward community.
Yeah. And it's one of the things that, like, when I talk to people about it, when I ask, again, this part of my job is talk with people who are suicidal on a daily basis. One of the things that people say is, like, I wouldn't know how to do it. Right. And then, or a lot of times we know that things like, we'll say it again, overdoses a lot of times don't work, right? Because of these situations, as people, we see a lot of failed suicide attempts, which is, again, what we want to see. In a way, we don't want to see completed suicides. We'd rather not see them, but we don't want to see the failed ones, but still, we'd rather see a failed attempt than a completed attempt.
Absolutely. One of the times where failure is the ideal.
That's what we want.
Yes. Well, in your work, you work with children, adolescents, and adults. And what are you seeing in terms of trends around depression, anxiety, ADHD? There's a lot of buzz on social media about ADHD and autism, and of course, anxiety and depression. I'm really curious about what lands for you in reality.
Everything is kind of kicked up. And I think that's kind of across the board. Everything is kind of kicked up. And I kind of joke about it in a way, or I say when I'm working with like med students or other students, I was like, if you want job security for life, go into the mental health field. You'll never be able to meet the demand by what's out there. Everybody is booked up for months or filled out for a reason, right? And it's because there's such that huge demand that's there. And when COVID occurred, it just exacerbated it. We were already in a situation where we knew that we were going to be behind. We knew there was a mental health shortage that was looming, and then COVID just turned it up to 12, right? Essentially, that's what occurred. So when I hear things like, oh, ADHD and autism, the whole neurodivergence kind of coming up a little bit more, I think there is a kind of two-pronged reason for why this is happening. One is that there's greater awareness that these things exist. And there's also then greater communication between people. So things like social media have created and fostered these communities of people, abilities for people to talk to each other and to say, I identify some of these things within myself is this what I'm going through? And, there's been kind of like the pros and cons and pushbacks, people being like, within the community of like psychiatrists and things like, oh, I'm so sick of seeing like, oh, these 40-year-old people who think they're autistic, and why does every adult think they have like ADHD now? And the reality is that 20 years ago, 30 years ago, they wouldn't have fit that criteria, right? They wouldn't have fit what the criteria of what autism was or what ADHD might have been, because we know that, again, we're going back to DSM a little bit, the definitions, the diagnostic criteria changed. 2013 with the DSM-5 was a landmark kind of change. It really broadened what these definitions were. And I think that was due to kind of realizing that people are not homogenous, right? People are diverse. They have this spectrum, these spectrum disorders that are there, and that things look different. So, it's one of those things where I can look at it, with my 40-year-old eyes now and say, my dad is probably autistic, right? He was always, he's an engineer. He was, he hits all those things. Like, even when we're like with family stuff, he likes to kind of hang out by himself. He's really content to like just be hanging out at home. There's a lot of things that kind of hit those boxes, but he's an engineer. He can talk. He's, he has a job. He's a wife. He's, my mom and my sister. He's got a family. All these things, and he wouldn't have fit what that definition of autism was, 50, 60 years ago. So that's one of the things. ADHD as well, similar kind of thing, is when we were forced to change how we do work, right? So ADHD is more so, it's the neurodivergence aspect where it's the broad spectrum, where it is more than just attention, more than just focus. We're designed, we're trained, we're educated to work a certain way, to function a certain way. And when COVID disrupted all of that, it really kind of, again, shined that light that like, hey, these adaptations or that inability to adapt to kind of this change really kind of brought this to light. And that's always when we see, during my training, is when we're evaluating for ADHD, it's those transition years. Those are transition years, especially like in kids and adolescents. So kids, we always look at that kindergarten to first grade jump, that third grade to fourth grade jump, because that's when we shift from learning to read to reading to learn. And that's when that kind of shows up, that third grade, around that time. Elementary to middle school to high school, college, et cetera, et cetera. That's when, those transition occurs. That's when those differences, whatever they may be, really start to show up.
So for a lot of later in life adults who are recognizing that something is different for them, something feels like they didn't have this information before, or they didn't have these experiences that they're having. And you're saying that COVID-19 really brought such a big and pivotal transition for everyone. But it shined a light on ways that they had been adapting, and the structures in place that were no longer there to support the way that people worked, and or the added demands that were now on their plate really resulted in a big transition that brought to light areas where they were functioning differently.
Yep, absolutely. And that's the major thing, is, again, that we were forced to this transition. Some people did well with it. A lot of people really, really struggled with it. And people who were getting by weren't able to just get by anymore. So that's why we see this rise in it, and going from there.
Interesting. So when people are talking about their neurodivergent experiences online, I mean, I've just seen a plethora of conversations shoot up in social media, and it's been really fascinating to look at the aha moments and the ways that people are understanding how their brain is developed and the reasons for it. And I look at so many folks having questions around the difference between the origin being related to neurological issues or environmental issues such as trauma. And I'm curious about how you look at conditions like CPTSD around neurodivergence in contrast with ADHD or autism, and how you make sense of, the nuances there.
Yeah, and it kind of comes back to my philosophy on, again, like psychiatry and diagnosis and DSM and stuff, is that life isn't, humanity isn't just nice little boxes, nice little check boxes, right? And we have this kind of spectrum of what's going on. So when I talk to people and they say things like, oh, I think I have ADHD because I have trouble focusing. And I was like, well, it's a little bit more than just I have trouble focusing, right? That doesn't make you have ADHD. Trouble focusing or trouble with concentrating is a symptom of depression, is a symptom of anxiety, a symptom of ADHD, a symptom of autism, symptom of so many things,
Of
schizophrenia as
trauma.
well, trauma as well, right? Of course. So there's that aspect where we say then, this is where we have, this is where I get my money's worth is when you spend that time with me, is like, we're going to spend the time and see how did this kind of play out over the course of your lifetime, and kind of create this timeline, this chronology to say, is it this, is it that? And then at the same time, doesn't matter what name we put on it. Doesn't matter that, like, hey, we're calling it ADHD or we're calling it autism. Doesn't matter that we're calling it complex PTSD or whatever it can be, because we're still gonna, treatment wise, whether it's going to be medications, therapy, combination, or something else, anything else that it can be, we're still going to do something for whatever the issue is that brought you to my office.
I think that's a really important point, and it's something that I talk with clients about all the time. How does this label or that label help you make sense of who you are, and help
Yeah.
you make sense of what you're experiencing and what your options are for addressing it, if that's something you choose to do?
Yeah.
And often it comes back down to stigma or
Yeah.
fear or some denial, especially for folks who maybe are having a hard time wrapping their minds around trauma that they experienced when they were younger, or maybe they don't have the verbal and conscious memories to understand the trauma that happened to them when they were younger.
Yeah.
So it's a little bit more challenging, and they often find diagnoses like ADHD something that they can digest.
Yeah.
And I'm not saying that they have to think of it in a different way at all, but when we break it down and really look at how someone chooses a label based on the language that's available in the ether, it's kind of curious to think about what we're assigning to the labels in terms of worthiness and prognosis.
Yeah. And I get this a lot, because again, like, I've been seeing a lot of people who are older in life, adult people who are coming in for autism diagnoses, or kind of evaluations. And I always kind of ask them in the last, like, end of the evaluation, I was like, well, what do you hope to kind of get out of this? What is kind of your takeaway? Because, like, we can't go back in time. I can't, like, give you this diagnosis at 5 years old, and then have all this slew of potential services or accommodations and schooling that are different, right? What are you hoping to kind of get from this? I can give you the diagnosis. Again, I can write a letter that says, hey, you have autism. But what? Now what do we do with that?
Yeah.
And
What
that's,
do
I think, the
people
next
say?
step. Yeah. It really it really varies. Some people are just like, well, this kind of provides a source of validation. It gives me a better understanding that, like, this is some of where my struggles were, some of the traumatic events that occurred. We can say, hey,
Mhm.
maybe you had autism, right? Maybe you had it. And then your inability to kind of connect with people, or, some of the bullying that you may have experienced during your schooling, the trauma that was associated with that, compounded with the autism, all these things kind of layered on top of each other. And this is maybe why you're presenting to me for depression, anxiety, whatever else it may be. Troubles with, like, attention and focus on top of your autism, potential autism that's there. We know that there's a huge comorbidity between autism and ADHD. I think it's like 40-50% or something like that. So again, these struggles with having jobs afterwards, maintaining jobs, struggles in schools, academics, life-wise, going through multiple divorces, etc. These things all show up, and they all have a reason. So being able to sometimes, like you were saying, give that diagnosis, it gives them a way for them to frame it, understand, and say, okay, I understand maybe why this is happening. But now what do we do? It's like, but now
Yeah.
what do we do? How do we adjust with this?
Absolutely. Yeah. For some people, really understanding the why can feel so empowering for how to move
Yeah.
forward. And for other folks, it can feel really debilitating. And so I think wherever someone is in their own conceptualization of themselves, their behaviors, their struggles, their strengths, I think
Yeah.
it's really important to emphasize that you get to be in exploration of that,
Yeah.
coming from multiple perspectives all the time.
Yeah. I had a patient who I did this with recently. And it was an interesting reaction, because he was like, I don't want this. He was like, I don't want this diagnosis, because this means there's something wrong with me. And I was like, well, let's reframe the conversation. Let's talk about it differently. There's nothing wrong with you. It's just things are different. And it's the same, that aspect of, like, I can give you the diagnosis, but how do we kind of move from there, and how we accept that? And again, just exactly what you're saying, where they're at and where they want to kind of where they're at in their life. So
Yeah. So you and your partner recently had a baby, right?
yes, yep.
Congratulations.
Number 4.
Number
So,
4. Oh, wow.
yeah.
Wow. Well, congratulations. What is it like to be present for number 4? What's different as a parent with your 4th child versus your 1st child? And I'm so curious, coming from the mind of a psychiatrist who studies child and adolescent behavior. So what are some of the observations that you have?
It's the biggest kind of adjustment is we had, I had my first 3 in my residency and my fellowship. So that was its own kind of challenge. We had them like kind of, right over the span of those 2.5, 3 years. So it was, they're from the first to the 3rd, they were, so what does that make 20 something, 36-ish months apart or something like that. So they were bang, bam, bam, right? All out there. We had our hands full for sure. It was definitely very hard to be learning to become a doctor, learning how to be a psychiatrist, and then having all of that there as well. It's one of those things where you like know too much sometimes as well too, kind of with, I really got into the aspect of like my child adolescent training was, my son was a year and a half and he was less than a year when we started that. So I got to see that really the early childhood stuff while we were in the training and going through there. So I just gotten used to like having these 3, right? I was doing well and out there in the world. It's difficult because you know too much. You kind of overanalyze sometimes. You look at everything. There were some concerns like, hey, is my son like on the spectrum? He's a little bit late, and is he like a little bit late in talking? Do we have to go down this pathway of like getting every evaluation and test done and X, Y, and Z? My wife is a nurse, so she has that medical kind of background as well. It's not psych, she's more into like the ortho and trauma and neuro stuff, but still like she's got a background in medicine. So that was the hardest part. My daughter, my first daughter, number 2, she had meningitis when she was like 2 months old. So again, that was the other, and I'm running back and forth still between fellowship and going to the hospital and going here and there, running to see the kids. So like that freakiness of like all these things are occurring at the same time. And then number 3 was kind of like a little accident, we call her, but she, she wasn't supposed to be here, but we love her still. So we had just kind of got used to like, having, now they're 8, 7, and 5, the eldest 3, when number 4 came along. And it's really interesting to see how they interact with each other, how they interact with the youngest one, how excited they were for the youngest one as well, the new one that came around. And then also just like, it's interesting because everyone's like, oh, you must be a great parent because you're a child adolescent psychiatrist. And I think like every mental health provider, we don't take our own advice, right?
Well, some of it.
some of it, right? No, there's definitely stuff that I'm like, oh, I look back and I'm like, man, I should have been doing this differently. I should have been treating my son differently. I shouldn't be saying these things, because at the end of the day, like I turn my brain off from work stuff when I come home. And then sometimes like, maybe I should keep it on a little bit longer, right? That patience that's kind of there. But it's really interesting too, because part of the reason I got into the field was we had, my wife and I, we had a friend or couple, they had a son who is like that level 3 autism. So a kiddo who has, again, nonverbal troubles with intellectual disability, all these things. And we were able to see like his development. I think he was born when I was like still in med school. And so we got to see his development, and we got to see the diagnosis, we got to see everything. And that's what kind of one of the things that really pushed me into the field, to be like, I want to work with kids like this. I want to work with this population of kids to see what I can do to help out. So there is that piece where you're like, I got young ones, I'm in the field, I have like, my wife is one of 6 kids. There's 14, now 15 little nephews, cousins that are there, nephews and nieces in like our little area. So I'm seeing everybody kind of their development and, over the past 10-ish years almost. So it's really interesting. But then everyone comes to me and is like, oh, can you help me and fix this too? And I was like, maybe not.
Yeah. What advice would you give to new parents on walking that line of being concerned and not being over concerned when they think that something might be going on with their children that developmentally, might be something they want to look at.
Yeah, I think it's better to just get it checked out no matter what. I get more concerned for people who are under concerned, right? I think that's the biggest issue. Is we see this a lot of times when parents will say things like, there's a late diagnosis for, again, and I don't mean like late diagnosis like 40, I'm talking about later diagnosis like maybe teenage years or 17, 16 years old, where I'll do the evaluation for like anxiety, depression. They may come to me after like again a failed suicide attempt, and then we sit down, we do an evaluation, and for like the partial hospitalization program, and it's like, you've had ADHD all this time. This is all due to your ADHD that nobody's kind of seen. And the thing that strikes me a lot is the parents will say things like, how could I have missed this? How did I never know? I wish I had seen this. I wish I could have done things differently. Or they'd be like, I remember a teacher had said something one time, and then I kind of dismissed it. Or I never really followed up on it. So that's what gets me more concerned, is again, the people, when they kind of dismiss things that people bring up, or they kind of minimize potential concerns. It's better sometimes to be a little bit more concerned and just get checked out a little bit. So trust your gut, right? There is always that parental kind of gut that like something feels a little bit off, something doesn't feel quite right. Let's investigate.
I really appreciate you saying that. And I agree 100%. I think sometimes parents' fears, and just a disclosure, I'm not a parent, so I don't really know what it's like to live that. But as a spectator and someone who works with many people's children, I think, and many parents,
Yeah.
I think that it's really hard to live in a space of fear around, are my kids okay? And so often, I think unconsciously, a lot of parents will minimize symptoms or minimize things that they could be concerned about, or in hindsight, wish they would have been concerned about, because it's really scary to imagine that something might be going on for your child that requires more maintenance. And then, of course, there's always sort of the unfortunate overcoupling of worthiness and perceived competence and whatnot, that comes with a lot of stigma carried with different diagnoses. So I think a lot of parents don't want to think about their child having a life that might come with some of that. So, there's a lot of mental gymnastics that get in the way of people taking proactive action. But I agree, get it looked out and try to stay on top of it. Because when I work with adults who do recognize in hindsight, nobody paid attention to this glaring behavioral concern, one of the things that they say most often is, I really wish my parents would have validated this or acknowledged this or helped me look at this sooner. Why didn't anyone do that?
Yeah. And that's again, a very common thing that I hear is like, and I see this too, because we know with neurodivergence, things like autism, ADHD, there's high family comorbidities. And, they'll often say like, oh, I had a sibling that had it worse, quote unquote worse, right? And they got all the attention. And because they were a more severe case and mine was more moderate or mild, I was seen as like, oh, I'm the good one, I'm okay. But still, your struggles are still valid. Whatever they're going through, the struggles that are still there, like those are still happening. Just because they may be, again, quote unquote, a little bit better than what somebody else is doing or what there's somebody else in the family is doing, it doesn't mean that it's still an issue.
Yeah, I agree. Well, for folks listening who are curious about kind of their own process, right, and their own experience or questions around whether they might be experiencing neurodivergence, what would you recommend as a starting point for them?
I think the biggest thing is getting in touch with somebody in the mental health field. All right. I think we all know, hopefully we all know somebody, whether that's a therapist, counselor, or something else. And, or even just your primary care doctor or something like that, just to be like, hey, I'm concerned about X, Y, and Z. What more can I do? There is, again, the burgeoning online community, which has its pros and cons. We can definitely find some things that are helpful that are there. Getting a little bit more information, researching, again, Wikipedia is pretty good. They've edited it a lot so that it's pretty good content that's there, reading through experiences and kind of seeing if you identify with things. And then again, bringing your concerns to the professional for an evaluation. The things that I say is like, when people talk about self-diagnosis and the issues that come along with self-diagnosis, if it puts you in front of somebody to kind of say, hey, let's talk with a professional about it and see if this is a real thing or not, then self-diagnosis is okay. If you're going to say, hey, I saw a TikTok video and I identified with one thing that was there, and now I have autism or ADHD or borderline personality disorder, X, Y, whatever it may be, that's where the problem kind of comes in. But gets you in front of somebody like you, somebody like me, totally fine. And then let us do our job a bit.
Yeah, I really resonate with that. It's sometimes the only thing that people see is a TikTok or a post on Instagram, or they've read a tweet somewhere, and it connects with them so deeply. And finally, I think they find resonance, and there's an enthusiasm in that.
Yeah.
Because for a long time, I think many folks struggle without language and without enough context or construct to know what's going on. So they hold on to something that gives them meaning, but there's a lot of risk in not investigating that further with a professional. Not that a professional is going to tell you that you're wrong about your experience, but your experience might have a different origin or a different treatment regimen or a different label, for lack of a better term, that might give you different meaning and different options.
Yeah, and I bring myself up kind of also as like an example of that, right? So I'm somebody who I've been open and saying that like I have ADHD. I am a later diagnosis in life, and this was like when I was out of fellowship after I was like an MD for however many years, that I was like, it was kind of a self-realization. I was like, oh my God, I've been doing all these evaluations for people and checkboxing and all the symptoms that are there, and being like, yeah, you have ADHD probably. And then I was like, wait a second, this is my life too. And so even for me, the professional who specializes in this, it took me 34, 35 years to kind of get to that point to say like, oh, this is the thing that I'm dealing with as well. And then when I kind of apply it to like my life in retrospect, I see how it touched so many different things. My credit score was crap for a long time. I had like a 500 something credit score because, the classic ADHD thing of like, oh, I'll pay this bill later. And when it's time to pay the bill later, it's gone. It's too late, right? This is before the time of like auto pay, but it was like the first thing you do when you open up a credit card or anything like that. Or things like when again, part of my journey is I failed out of dental school because I thought, I could just like do an all-nighter for all these exams the night before, like I did in high school and undergrad. And you can't do that with that much information. So that's something, again, when looking back in life, I was like, my life could have been very, very different if this had been kind of recognized or treated much earlier.
Yeah, I so appreciate you sharing that. It really is so important to like give ourselves a tremendous amount of compassion and to consult with people around us who are skilled to evaluate these different kinds of conditions, because we all have blind spots and we all have different motivations on how to get through this crazy thing called life. And so sometimes we can't see the forest for the trees when it's our own story. But that's one of the interesting reasons why there's so much me-search in the research for folks who are involved in these professions, the helping professions.
Yeah, absolutely.
Yeah. Yeah. Well, thank you so much. This was a really informative and lovely conversation. For folks who want to work with you or follow you on social media, where can they reach you?
Yeah, so I have my main thing is TikTok and on Instagram. I started a YouTube channel recently as well, where I'm doing some podcasting and interviewing as well. And I'm really enjoying that aspect of it too. I think it's just like a great thing because we get to, and mine is a little more to kind of say, hey, let's talk about psychiatrists and other mental health people as like human beings as well, and seeing what else they're doing. But so that's one of the things. It's all under the name The Kicks Shrink. So The Kicks, KICKS, and Shrink, SHRINK. The name comes from my love of sneakers, because one of the best things about being a doctor was finally being able to buy all the sneakers that I was deprived of when I was a kid. So that's that's where the name come from. People think it's, sometimes they read it quick and they're like, oh, it's the kink shrink. And I was like, no, we're not that one. that's maybe somebody else, but not me.
That's maybe a different channel. Yeah.
Yeah, maybe a different channel.
Maybe my channel.
Yeah. well, which is all good. So, yeah, I just had Dr. Raina Mullick, who's like huge on YouTube. Huge, like over 1 million followers on YouTube, and she's a urologist. Does a lot of talk about sexual health. So that was like a really, it's super important when we talk about sexual health and mental health and overall health in general. So these things are very much, intimately intertwined, pun intended, perhaps. So.
Yeah, great. All right. Well, thank you again. I really appreciate your time. And thanks everyone for listening to this episode. We'll see you next time.
Thank you for listening to the Modern Intimacy Podcast. On Instagram, follow me at Dr. Kate Balestrieri and at The Modern Intimacy. On TikTok, check me out at Dr. Kate Balestrieri and on Twitter at Kate Balestrieri. Everyone has questions about mental health, sex, and relationships. Send yours to me via DM on Instagram or email them to questions@modernintimacy.com and I'll answer some at the end of each episode. Visit the website, modernintimacy.com, to schedule a consultation with a member of our team or to sign up for our newsletter. Let's meet back here next week. New episodes air every Tuesday. Reminder, this podcast is for education and entertainment purposes only and is not a substitute for mental health services.